Good morning, everybody. Welcome to our masterclass today. So my name is Juliet Kumar. I'm just going to introduce the session. I work for the Innovation Agency, which is one of the 15 academic health science networks across England, and we're part of the Northwest Collaborative. Next slide, please. So the Northwest Collaborative, we work together to bring these masterclasses to you. We're made up of these 6 organisations: Merseyside Internal Audit Agency, AQUA, the Northwest Leadership Academy, Northwest Employers, and the Northwest Association of Directors of Adult Social Care, and ourselves at Innovation Agencies. Next slide, please. So I'm here to introduce our chair today, Liz Ashall Payne. So Liz is an inspirational leader and has many accolades as a leading woman in tech. In fact, last night she was receiving an award as a finalist for the Entrepreneur of the Year. And last week she was invited to Buckingham Palace to meet King Charles in recognition of her company's contribution to the economy. However, she started her career in the NHS as a speech and language therapist, and I was fortunate enough to have been connected with Liz nearly 7 years ago when I started with the Innovation Agency. Liz had just left the organisation to set up her company ORCHA, which helps clinicians and users to select the best healthcare apps amongst thousands in the market. They review and rate apps so that we have confidence that they are safe to use for us. So Liz is a mentor, coach, mother, woman in tech. She's busy and always brings great energy to whatever she does, and I'm certain you're in safe hands today. So without further ado, I'm going to hand over to Liz. Welcome, Liz.
Oh, thank you so much. That was a lovely welcome. And thank you so much for inviting me to join today. I'm speaking would be able to mute. I don't know whether we're able to. There we go. Thank you, Mark. That's really helpful. So yeah, if we can just maybe keep ourselves on mute when we're not speaking, that's really helpful, just to prevent as much background noise as possible. So thank you so much for that lovely introduction. Yes, seeing the King last week was a bit of a pinch me moment. I still can't quite believe that I went. He was a lovely man. Lots of people have been asking me how he was. I've got to say, very relaxed, very easygoing, informal, really nice guy. And I'm really honoured to be chairing today's session. And as Juliet said, my background is clinical. So I started work in the NHS about 24 years ago, working as a speech and language therapist. And quite often people will ask me, well, how did you go from being a speech and language therapist to running a digital health company? And of course, it wasn't linear, but the passion that sits behind what I do today is exactly the same as the passion that sat behind what I did all those years ago. And that was predominantly that I wanted to help people. So when I was 15, 16, you get asked at school, what is it you want to be? And, you know, my children are being asked that question now. And I didn't know what I wanted to be, but I knew what I wanted to do. I wanted to help people. And I found myself, therefore, looking at roles within health and healthcare because it really resonated with me. Now, I decided I didn't want to be a doctor or a nurse because I'm really squeamish. And I always got the reports at school saying, could do better if spoke less. So the role of a speech and language therapist really appealed to me. And so I went off and did my training. And I was really excited on day one working as a clinician in the community with children, because I thought today I'm going to start helping people. And at the end of that first day, I felt really frustrated. And the reason I felt really frustrated was because I'd only been able to see 6 patients. And it seems really basic. But for me, I felt really frustrated because as a clinician, I could only see 1 patient at a time. And waiting lists were long. There were many people who needed interventions and access to my knowledge and skill that I'd developed. And so I thought, how can we start to help more people? How do we provide more access to more healthcare? Now, this was way before we even had laptops or computers on our desks, let alone smartphones in our pocket. So that started me on a journey of thinking, well, if we could do things differently? Could we see more patients? And I got really interested in quality improvement and lean methodology, and spent the following probably 10 years really looking to reorganize pathways, strip out waste so that clinicians could see more patients. And it was really transformational, and we were able to start seeing somewhere between 10 to 12 patients a day per clinician, and we massively reduced our waiting times and waiting lists. But for me, it didn't feel enough, not least because I had to invite patients to see me when I could see them, and that was also a frustration for me. And then you fast forward a few more years and you start to see the rise of digital. We all have smartphones in our pockets, and there was the rise of digital health and health apps. And I thought, well, this is it. This is the answer. The answer is we need to just put digital health into the hands of our populations and patients and provide them with access to high quality digital health technologies. But of course, it's not that easy, is it? It's not that simple. And so I got obsessed with, well, why are we not able to distribute digital in the same way that we do with other things in healthcare? And I've got a few slides that I wanted to share with you to explain what we did, because what we did was really try and disrupt, in a very positive way, access to digital health technologies. So I'm just wondering if you could bring the slides back up, and then I can share a few visuals. And so for me, when I started to think about, well, how do we get these technologies into the hands of people and patients? I wanted to, I don't know if this slide can come up, I wanted to look at other ways in which we distribute health to patients. And the obvious place to look was in the world of distribution of pharmaceuticals and drugs.
Sorry, Liz, just jumping in. Apologies, I don't have those visuals.
Oh, okay. I will. That's okay. I will bring up my. I've got them here. That's no problem.
No, just co-host. Thank you.
Oh, that's okay. No problem. Can you see my screen now?
Yes, we can, Liz. Thank you.
Brilliant. Okay. So we shall move that out of the way if I can.
You just need to go on slideshow.
Yeah, I'm trying to get to that bit.
Oh, bless you.
Ah,
Bit of a delay, isn't it?
Yeah, I just can't quite get to that bit. Oh, there we go, slideshow. There we go, from the beginning. And so I started to think, well, how do we distribute other things within the world of health and healthcare? And like I said, the obvious place to think was, well, how do we distribute drugs? Because every day, millions and millions of drugs are prescribed on a global basis, and that's done in a very safe, trusted way. And so I thought, well, what are the building blocks to us enabling that to happen? Well, basically, the first thing is we trust the drugs that we prescribe, and that's because a drug, before it gets to market, has gone through a licensing process. So before a drug gets to market, it goes here in the UK, obviously MHRA and NICE are evaluating that drug for efficacy and safety. And in the course back 8-10 years ago, we didn't have anything like that for the world of digital health, but yet we had access to hundreds of thousands of digital health technologies. And so trust was a real challenge. The second thing was, once a drug has been evaluated and tested, it's then put into the curriculum so that prescribers know about drugs, and it's also put into the British National Formulary so we can check for any contraindications, and that's about raising awareness. And of course, in the world of digital health, most people weren't aware that there are technologies that could help themselves or their patients, and so that awareness was missing as well. The third thing that we have in the world of distribution of drugs is the ability to prescribe. So, of course, years ago, that was through paper prescriptions, and now more predominantly through e-prescriptions. And that's about providing access to the right drug for our patients. And of course, again, in the world of digital and digital health, what we see and what we know is that people will wave their phone at a patient, and that doesn't necessarily mean that the patient is accessing the right technology for them, because I may say to you, download app A, and you may go home and think, oh, did she say app A or was it app B, and then get the wrong technology. And of course, within the world of medication, there is a clear governance structure which manages any risk. So through that infrastructure, we know what drugs have been prescribed to whom, and if a future error or concern is raised with a drug, we know where those drugs have gone. And of course, that isn't the case, or wasn't the case, in the world of digital health. So what I wanted to do when I set up ORCHA was replicate that in the world of digital, so that we could have a safe infrastructure that allows for deployment of trusted technologies to get to patients. And that's really what ORCHA are about. Now, just to give you a little bit of an idea, there are currently 365,000 digital health technologies available. Now, the first thing to also mention is that less than 20% of those technologies meet the quality criteria that you would expect. And unfortunately, that's a worsening picture over time. So less and less technologies are meeting the criteria. Now, here for the NHS, we have something called the NHS DTAC. If you haven't heard about the DTAC, please do reach out. Very happy to share details of that. NHS England are currently doing an audit of DTAC technologies across the NHS. But the DTAC is the minimum standard for entry into the NHS. And alongside that is something called the NICE Evidence Standard Framework, which sits on top of the DTAC. Now, what ORCHA do is we assess to those standards to make sure that the technology is safe for use. But of course, the technology, unlike a drug, updates and changes. So that review and evaluation process is something that is updated and reevaluated every single time the technology changes. Now, that then lays the foundation for building trust in the same way we have for medications. The next thing that we then need to do is raise awareness. And the awareness is very much about educating our teams around what's out there, educating our population about what's out there, and providing access, the third area, to those technologies. And so what we do at ORCHA is we provide education and training. We do that in partnership with Health Education England, and that's freely available. I'll put the link in the chat. You can deploy that. That's free to use. It's all CPD accredited, and it's low-level education and raising of awareness for everybody to understand a little bit more about digital health. The access piece is then something that we do on two levels. The first is we work with NHS partners predominantly, but we do work with councils and social workers to provide access to digital health technologies through focused health app libraries, which are distributed to a target population. And then we create digital health formularies. So in the same way that we have the British National Formulary for drugs, we create bespoke digital health formularies, which enable health or care professionals to be able to search for, find, and then finally prescribe or recommend a technology direct to the person's phone that they want to recommend that technology to. And that's really important for risk management and ongoing governance, because the trust element is a continuous cycle. We're able to have an audit of what technologies have gone where, and if a future fault is found, we can do a recall. And this is really it's been a really disruptive process, but in a positive way, because what we're doing is we're providing access to trusted technologies that are safe and efficacious, but also managing any future risk, but bringing health and care professionals with us in a way that makes sense through education, training, and access to information that they need. And before I hand over to the other speakers, I wanted to share with you very high level how digital can really support challenges that we have at the moment. So I've given the example of elective care here. We all know that elective care is a real challenge for healthcare systems at the moment globally, not just here in this country. So, but here in the NHS, we have nearly 600,000 people currently on the elective backlog just for eye services, just for ophthalmology. So huge numbers of people waiting for support. And one of the things that we do when we review a technology and evaluate it is we're looking at the evidence of efficacy. And I've given you one example here. So one of the things that we do when we're assessing is we're not just assessing is it safe and efficacious, but where in the pathway will it have the biggest impact. And you can see some evidence here for one of the digital health technologies that we've assessed, which shows that it can save 423,000 hours of consultant time, over nearly 2 million hours of a nurse time, and save £71 million in a year. And that's one technology. The challenge is which technology is that? And so the first thing to say is, of course, we can use technology in lots of different clinical areas. So what we did at ORCHA, and we have toolkits, which again, very happy to share this. We have 4 key clinical areas around the elective recovery. We're adding to these all the time, but these are 4 areas: 1, cardiology; 2, dermatology; 3, MSK; and 4, ophthalmology. And what we've done is look for technologies that can help with these 3 key areas. 1, to support people who are waiting. How can we support patients to maintain their optimum level of physical and mental well-being whilst they're waiting? And how can technology help to prevent deterioration so that people are in their best position pre-operation? Because obviously if they're not, then we could see worse health outcomes. And of course, to maintain the physical and mental health of patients. So that waiting well is really important. Now, post the elective recovery, the elective care, what we then need to do is think, well, how can technology help with remote monitoring and that prehab, and obviously the post-recovery and rehab. And of course, technologies can support all of these different areas. And it's really important that we understand which technologies can have what impact for whom at what point. And of course, there's massive benefits. So each of the different toolkits that we've created includes a full evaluation framework to look at the benefits of implementing technologies across a pathway. And we've seen improved quality of life. We've seen a reduced demand on primary care support services while somebody's waiting. We've seen a reduced length of stay during treatment, reduced complications, and really importantly, reduced readmission rates. So I just really wanted to share with you a specific example of how digital can be a disruptor in a very, very positive way. So I hope that's given you a little bit of an overview of how digital can support and how I've ended up getting to where I am. So what I wanted to just do is just run through the agenda for today. I'm going to be introducing Rachel very soon. Unfortunately, Rachel is on a delayed plane, so isn't going to be joining us, but she has been very creative and has a video recording of her presentation. So I'll be introducing that in a second. We're then going to have Michael from the Telecare and Telehealth Manager at the Wirral Council. We've then got Dr. Simon Bowers, who's a GP and Chief Medical Officer at Blinx Solutions. We'll then move into some breakouts. We'll then have a panel with Q&A, and then we'll have some closing remarks. One of the things I'd like to invite you to do during today's session is to tweet. Share what we're doing today, share the knowledge that you learn, and engage with other people. The Twitter hashtag is #CollaborativeNorthwest. Please do engage with that. And you will have heard when you joined today's session that it is going to be recorded If anybody didn't want any part of what they're going to share or say today, please do contact the team and we'll make sure that part is removed. Otherwise, we'll assume that you're happy with this being recorded. So thank you so much for indulging me in sharing my story and sharing a little bit about the work that we do at ORCHA. And I'm going to hand over to Rachel. As I said, she's on a plane, but she has been very creative in creating a video. So Rachel Dunscombe, for those of you who don't know Rachel, and I know that many of you will, is the Chief Exec of the NHS Digital Academy, which is leading learning in digital health for England and Scotland. Rachel is also a visiting professor at Imperial College Medical School, as well as a director for digital at Salford Royal. Rachel serves on an international advisory board of CLASS and is the founding Chime ambassador in the UK and chair of the HIMSS UK advisory board. So she has a lot of hats to wear, but I will hand over to Rachel, who's going to be joining us on a video.
Hello, Rachel Dunscombe here. I'm delighted to be with you at this Digital as a Disruptor masterclass. Now, I'm somebody that's based in the north of England. I'm very privileged to be able to travel a lot with my job, working in digital healthcare. And that's why I'm not with you today, because I'm out and about working with the Middle East and the US. I'd like to talk to you a little bit about our region and digital disruption in healthcare. My background has been as CEO of the NHS Digital Academy and also as CIO of the most digitally mature organisation in the NHS. So I've worked very much at the coalface of transforming healthcare with technology and data. So first of all, digital as a disruptor, what does that really mean? For me, we're, hitting the next industrial revolution. And that revolution is one where we can use intelligence and automation to augment humans and to do things that humans very much can't, or shouldn't have to do today. So when I say can't, for instance, some of the work that we do in digital cellular pathology, we would never have enough pathologists to look through the data that we're going to collect that computers can analyze. Shouldn't have to do. We have humans cross-keying data from one system to another, which is really quite pointless in this day and age when humans can add value elsewhere. So what is happening in healthcare? Well, we are on the cusp of the next industrial revolution, and that's very pertinent for the North in particular. If you think about, the rocket, the steam engine, when we had that industrial revolution, that went from Liverpool to Manchester. I actually used to live as a child by the rocket in Liverpool, and now I live right next to the train line on which it travelled. That was very impactful for the world. But also, the computers at Manchester University, the looms that we had during the Industrial Revolution when we automated weaving. Pretty much every industrial revolution has had a really strong base or started in our region. So we're very good at changing the game. And that was also true and is still true of digital healthcare. There are very many things that we've done here in this region that are first or new or trailblazing. And things like the Salford Lung study, where we put in the first real world evidence system for looking at a population as part of a clinical trial. That's an example of one of the great things that we have done here in the region, and I was personally involved with. So as we come to this next industrial revolution, what's it about? Well, it's really data-driven. It's about data and automation and intelligence. And it's about things moving a lot faster and us being able to do a lot more. We've got the wonderful Hartree Centre as well over in Runcorn, Dursbury. The Hartree Centre, of course, is expediting quantum computing and digital twins, which is very much part of this next wave of, industrial development. We also have the great work that's happening with the Turing Institute in Manchester. And these things are all moving towards us being able to use the next generation of data-driven intelligence solutions for healthcare. Now, why is this exciting? It's really exciting because it will give us more capacity and more quality capability. And there's a wonderful movement that was started in Manchester, which has now moved across Europe, called Data Saves Lives. And what we will be able to do is to pull together the data for an individual like me or you, or a population, and risk stratify it, work out, personalized care, precision medicine. And, what does that mean? For me, I'm diabetic. What it means is they can hold all of the data about me, my diabetes, my other conditions. And if they get a new blood test result in, or, a new set of data from me and my wearable device, my app, they'll be able to say, well, what does this mean for somebody like Rachel, who's diabetic, with her history? And suddenly they start personalizing. And that means that we are using our resources in the right way. We're using it for people that need care. And we're making sure that those people that are able to self-care and self-manage will be able to interact with the system in very much a consumer type way as well. We will be providing, the sort of apps and wearables that individuals need to self-care and self-manage. That's important because the biggest actor, the least underutilized resource in our system is the citizen. Many want self-care, many want self-managed. They don't want to come into a hospital or outpatient appointments if they don't have to. And in this new age, we will be able to allow them to do that and only see them if needed, which is, it's more effective for the system, but it's also more convenient for the citizen. And so we're driving towards this new age of healthcare, which is more about that precision of seeing people when needed, knowing exactly what treatment they need, putting it into their personalized context, including the medical data and their preferences, their beliefs and everything else. But that's going to need a lot of skills. It's going to need some real skills around data. It's going to need skills around intelligence and AI, skills around leadership, skills around co-design, ethics, data, and so on. And so what we are finding is that there's going to be, a big growth in the digital health profession that I belong to. And what I'm really passionate about for the North of England in particular is that we need our schools and our universities to be priming people for these careers. There is nothing more exciting to know that data saves lives than that you are working on that data and helping save lives and improve lives. But what we've not done really is align our schools and our university programs to produce the graduates we need. Really big gap, actually. For England by 2030, even with the programs we have put on, there's going to be a gap of 32,700 individuals that won't be in the system that we need. And so what has to be done, and what I really want to have happen for the North, is to create that pipeline of talent that will move into this career. And personally, I find this career so fulfilling. I'm sure a lot of other people as well do find it fulfilling. It's one way of using your technical skills to do something really worthwhile. And also, it is so challenging. It's constantly presenting, more data, more situations, more complexities. The human body really is more complex than almost anything you can imagine. And we keep discovering more with science that we can measure and improve in terms of human outcomes. Now, the North of England, as I said, has always been very, very good at creating the next industrial revolution or the next innovation. And for me, this region has excellent NHS organisations. It has the right population to do research over. To do research, you need a microcosm of the globe, and we have every possible sort of group. Liverpool used to be a port, and it's always had very many diverse communities. Same with Manchester. That means we've got great data to do research with because we represent the world. We have the M62 corridor with all the digital companies. We have some quite disparate skills as well, like 3D, gaming, which are pertinent to healthcare for 3D visualization. And we have, some amazing universities as well. What we need to do is make sure that we start creating that digital health talent and pipeline it so that we can serve all of those industries and the NHS as well. And we can create both a sustainable NHS digital sort of service, but also a set for industries and academia research around it, which are all sort of symbiotic. They all support each other. And that's something that I hope by 2030 that this region is leading on for the UK, because I think we have all of the ingredients here. And I think we also have people that are really passionate and enthusiastic about digital health in this area. In terms of where I think the NHS will go and how the NHS will look, if we get this right, we will automate what we don't need to do. We won't have people cross-keying things from one system to another. We will be using intelligence to be far more precise and deep about diagnostics. We will be quantifying risk and treatment for individuals, and we'll be providing that real convenience for the citizen to self-care, self-manage, self-report. But that's going to take some time because we have quite a long journey to go on in terms of engaging with the citizens, understanding which solutions are appropriate. And I think there will be a whole area of publishing research around the efficacy of digital health solutions with different populations, different demographics. And so we can see, what's effective for which communities. I would really welcome your feedback. I'm on Twitter, so I'm at UK Penguin, because for me, we're all the lifeblood of this region. And I always enjoy talking to more people about how they see, the digital disruption playing out and how they see it playing out for, different sectors. So please do tweet me at UK Penguin, even though I'm not physically with you in Liverpool. I will very much be online listening to what you're saying. So to summarize, I think we have an excellent set of opportunities in our region. We need to get the workforce bit right. That's absolutely key. Our NHS needs a new digital, operating model, which, is starting to emerge. We must not forget that, we started a number of industrial revolutions. And I think that we can be, at the helm of this next digital health revolution. And we have basically got the greatest universities, NHS institutions, and surrounding industries in the Northwest to help us with this journey. If you want to be a digital disruptor or work in this space, my advice really is that there are multiple entry points into digital health careers and how you can improve lives and save lives. The ones we really need at the moment, our biggest gaps are in digital and data and AI. They're careers worth going for. And I think people that have also got clinical qualifications very successfully can transition into technical careers as well. So I encourage nurses and doctors to move into data and digital roles. But I'd be very keen to hear from you, as I said, so tweet me at UK Penguin, and thank you for letting me speak to you today at this session. Take care and I hope you have a great day.
Thank you so much. And what an inspirational presentation we just had there from Rachel. She is an absolute powerhouse, and as she said, do feel free to tweet her. She would be delighted to hear from you. And thank you for the message that came through in the chat, which was from a lady called Louise, saying that it's her daughter's parents' evening tonight. It's also my son's actually, and they're discussing her GCSE choices and the computing teacher. Oh, Louise, you've put your camera on. Yeah, thank you so much, and it's inspired you to encourage her. And I mean, I'm a real advocate for women in technology, and as Rachel said, you don't have to be techie to get involved. The passion and the mission behind digital is very much about improving lives But also, as Rachel said, this is our future workforce, and it's a real disruptor, but it is also a massive opportunity for future careers, and this is our new industrial revolution. So thank you to Rachel, and I'm going to move on now to our next speaker. So Michael, I don't know if you're able to, there we go, we've got his camera on. So I'd like to introduce Michael Hanrahan. So Michael has also a very impressive backstory. So Michael has worked in a variety of health and care roles across the public sector since 2001. Michael's focus has been on innovation, service redesign, and delivering improved outcomes. Michael's worked in the Wirral since 2018 with the brief to identify and deploy effective care technologies designed to transform service delivery, increase the ability for people to have more choice and control over their lives, and reduce reliance on traditional care services. After introducing a successful telehealth service in the Wirral, he's now managing the deployment of technology-enabled care across the community care market, including the analog to digital switchover of Telecare, which is not a small feat. So Michael, welcome to today's session. We're really looking forward to hearing what you have to share with us.
Okay, thanks very much, Liz. Good morning, everybody. As I've already been introduced, so I won't go on. So just have to go on to the next slide, please. I thought it'd just be useful for everybody just to understand the context in which I'm working at the moment. So Wirral is that little peninsula that pokes out. It's where you get the ferry across the Mersey to. We're a unitary authority. We've got one big hospital. We've got 2 community health trusts. Our adult social workers are actually employed by each of those trusts. And we've probably got a relatively mature health and social care system, in that we are much more used to working with each other. A little while ago, until the breakup of the CCG, we formed Wirral Health and Care Commissioning with the CCG and the Adult Social Care Commissioning team. And I think I've been very fortunate in arriving in an area and working in an area where our leaders, our system leaders, are really interested in technology and the impact that technologies can have around better outcomes for individuals, but also those efficiencies that in particular we need to drive to. Next slide, please. So I constructed this vision, or this vision was constructed really to try and help everybody involved try and understand what it is we were seeking to do. And that was really to bring a genuine connected care and support platform together that would include our call centre, the alarm systems that we use in Telecare rely on, our domiciliary care staff. They're pretty much all equipped now with digital technologies. So when they arrive at a person's house, they literally tap in, the care plan appears on their handheld device, they deliver the care, and then they leave, tapping out, and then rather than sitting down spending 10 minutes of that visit writing up notes, they can simply speak into their device. Those notes are captured from voice into text, and on they go to go and provide care to the next person. And obviously all that information is digitized and then becomes available. We have our core systems, things like the Wirral Care Record, which is that combination of health information from all the different sources, so it's all there easily and available in one glance by a clinician, and obviously Liquid Logic, which is the local authority's case management system for social care. We encourage families, like everywhere, we encourage families to get involved in the care of their loved ones and be genuinely involved, being able to prompt as well as see the care that's being delivered. And then we move on to the technology that is sort of pouring really out of people's minds and out of small factory units across the world, that turns our homes into smart homes. So I guess a lot of this technology originally started in the comfort and convenience market. Those huge villas overlooking the Pacific in California, people couldn't be bothered opening the blinds or the curtains, so they attached little motors and they had a remote control unit. Translate that into the world of learning disability or physical disabilities, and all of a sudden you're giving an awful lot of power and control back to people, because they can start to run their own lives, manage the space that they live in far more effectively. There are sensors that can tell us whether you increased going to the toilet, and that might indicate a UTI. We can see that personal care is being completed because we can see the shower or the bath is being run. A whole host of all of those technologies can come together to provide a smart home and telecare. As has been mentioned in the previous presentations, the move towards telehealth, virtual wards, that whole area of being preventative. So if you've got people with long-term conditions that occasionally exacerbate, is understand what those exacerbations look like in the earliest hours, the earliest days, before it becomes an acute event and attendance at hospital. Most of all is bringing all that information together with and for the individual, and also enabling the individual to use some of those technologies. Because if you connect it to the internet, so all this stuff works, why not connect that person in a different way, in an appropriate way, so they can start to develop networks of their own, develop relationships, share their ideas, and hear other ideas. So next slide, please. So part of that vision that I talked about is very much around the monitoring. So we have Telecare, and you can see that whole range of devices. We can see when people, are in bed, that they're getting enough rest, that they're moving around their house, see the temperature of their home, make sure it's healthy, make sure it's safe, particularly now with the fuel crisis. We can see lights going on and off, just make sure that they're not moving around in the dark when they're going for those midnight visits to the loo, because that's a major source of falls and trips. We can look at medication, how medication is being taken or not, and then intervene, and at least understand if somebody represents to a GP or to another clinician. We can understand the reason why they're not really responding very well is they're actually not taking their medication, or they're not taking their medication in the way it should be taken. Now, of course, a lot of people get on just fine, and that's great, and we can start to understand what living well looks like, and that's why we capture that information, and we can just pile it back into it. We can pile that into a data analytics package, and of course, if things aren't going well, it means that we can intervene really, really early. And it's exactly the same story really with telehealth, except obviously at that point we'll be taking those clinical measures. So the blood oxygen levels from a pulse oximeter, blood pressure, temperature, and who knows, some of the other systems. I've already seen some things where we might be able to begin to monitor tidal breathing, and also be able to monitor somebody's both skin and core temperature remotely, so you don't actually need a device fixed to the person. And once again, if people are living well with their long-term condition, that's fine. What does that look like? How does it feel for them? We can capture some qualitative information as well. And again, if things start to take a downwards spiral, we can get in there, a phone call from a nurse or a visit from a district nurse before the person panics, hits 999 and gets that conveyance to hospital. Next slide, please. So the proof of concept around our telecare in Wirral was in that top left-hand corner, in terms, and I know it's not very large, I hope people can see that, but that blue section in the top left-hand corner is our demands were of any new telecare, that it had to do all the stuff that the old telecare did. Because as basic, sometimes as primitive as it was, it did actually work quite well. And when we knew how people operated with it and dealt with their telecare. But what we also wanted to do was take advantage of digital. And we recognised that the use of different types of sensors could give us more of an insight into how somebody was living their life. In that sense, it gave them greater personal independence, because we wouldn't be unnecessarily bothering them. If any of you have got any experience of telecare, we see panic buttons pressed, we see falls detectors going off all the time, and very often it's just by accident. They just press the button inadvertently, or they've knocked their wrist against the table, and the device has thought, oh, the person has fallen. So lots and lots of disruptive calls to an individual. So we felt that the digital technology would give us some advantages there to try and cut out those false alarms. Using activities of daily living sensors that simply measure whether somebody's in the room or whether they're moving around. And it's not so much what they're doing in that room at any one time, but it's that pattern of behaviour. What time do people go to bed? What time do they normally get up? And how much time do they spend in their lounge? Are they going to the kitchen? that might give some evidence that they're eating and drinking. Are they going the loo? Because we know that that's a major consideration for people with UTIs or with constipation. And then actually alert services in the event of emergencies, if necessary, but actually get in there beforehand. And we're also hoping that looking at the pace and quantity of movements within a home, could they be predictors to falls? So if we see someone perhaps starting to move less, and when they do move, they move more slowly, does that correlate with a fall happening at some point in the future? And if we can start to understand some of those signature activities, it might give us that eye in again to get in and do that strength and balance training, or understand that the walking aid needs improving to prevent that person from having a fall. In the top right hand corner, we very much want families to become far more involved in the care of their loved ones. And again, because this information can be shared on a variety of dashboards, it can prompt texts. So imagine, you're busy at work and you get a text at 9:30 that just confirms that your elderly mother is up and about. She's been to the bathroom and she's downstairs in the kitchen having her breakfast. Means you don't have to spend the rest of the morning worrying about, oh, mum wasn't too good last night, I wonder if she's got up okay. So that can be really, really effective. And then in the bottom right hand corner is actually, again, all this data being used to inform social care assessments and social care reviews, and also giving some of that subclinical data to clinicians that provides that sort of much rounder information rather than just the bald statistics that come from perhaps things like telehealth. Next slide, please. So our approach was very much jointly between the local authority and our local health organisations. We split out really where those benefits would be, and in some areas it was an equal benefit to both organisations. In others, the NHS benefited more than the local authority, and in other circumstances, so around support plan efficiencies, for instance, for people with learning disabilities, nearly all of those efficiencies were beneficial to the council. Using that visioning that I've just described to you, we got political support from our elected members. They agreed that capital investment. And then we had a choice. We could move from analog, because the analog telephone lines are being switched off, to a passive digital, or we could move to active digital. And we favoured the active digital because we felt that only one of those would really provide the transformation that we needed and provide some of those cost avoidance and cost and those efficiencies that were required moving forward. Next slide, please. So there were no real exemplars, there were no real examples that we could really delve into and find out what had other people done. Although there was some pilot work in Scotland and in other parts of Europe. Most of the work we felt should be done by learning by doing. So it was small pilots, focusing on benefits, working with stakeholders. And we decided to put the proof of concept together with our contractor provider of Telecare, a company called Mediquip. And we agreed that we would go with the active daily living sensors deployment, that always were going to have, I guess, some element of risk associated with them and acceptance. Next slide, please. So when you've got we've got nearly 4,000 residents now in receipt of Telecare, so the scale is large. We needed to understand the costs a bit better because the digital Telecare was more expensive. We needed to establish whether it actually worked. We've got lots of shiny suited salesmen presenting all sorts of fantastic products, but we need to make sure that they work in the real world, in people's own homes. The acceptability of this new approach, absolutely crucial. What was the data quality really going to look like? Would it give us the evidence and the results that we required? And do the benefits scale? As I mentioned before, most of it had all been done in small pilots, maybe in things like sort of supported living type environments or sheltered accommodation, where you've got just that very small community, probably very, sort of quite a homogenous group of people. When you're using Telecare across a much wider community, like in Wirral, over 300,000 people, with a population of over 300,000 people, people are very, very different. They have very different living styles, very different living standards. So we wanted to make sure that those benefits would scale to our residents and recipients of Telecare, to the local authority and its partners, and also to the organisation that we're working with Mediquip. As a commercial organisation, how could they take this offer and spread that innovation across the rest of the country? Next slide, please. So we identified two options. The first option was a company called Essence, and that's what we call a closed ecosystem. Essence will only work with their own peripherals, so that puts some cost pressure, but also satisfies and minimises some of the risk. So we decided to go with a closed system where we had sort of total control, effectively total control over what the devices would be, what they would look like, and how they would connect. And next slide, please. And then we identified a small company called Alcuris that has subsequently been acquired by the Access Group. And there are a couple of new players in this field. And they operate a system that's agnostic. So they effectively provide a base unit, which is that little sort of turquoise and black device at the bottom center of that little display. And they work with a whole range of different peripherals. And it doesn't matter who their manufacturer is. So it gives us greater flexibility in terms of managing the costs. It also gives us greater flexibility in using specific peripherals that meet very, very specific needs. So there's a greater opportunity for personalization. Next slide, please. Oh, excuse me. There's a, for deployment, we had the physical delivery and installation of the equipment, and that was all taken care of for us by Mediquip, contacting residents, giving them information about what was happening, why we were changing their system. And then that led to that deeper thinking really around the organisational changes. So we would need new types of response services. No longer would we be always responding to somebody's fallen. Well understood. We've trained responders to go out and to go and deal with that fall. And this was more about, is there a sign of somebody deteriorating here? What should be the approach? Should it be a phone call? Should it be a visit? Do we let a family member know? So we had to start thinking about those new pathways to go and support people. We knew that we would be moving from the well-established pattern of fail and fix. So we're great at eating and drinking too much, not really doing what we should do in terms of exercise. Something goes wrong with our bodies, and the NHS amazingly puts us back together again, and we come back out of hospital fixed. But we do need to move more to a predict and prevent. If we know something's going to happen, intervene and stop the fall. If we know that somebody's going to the loo quite a bit, let's intervene and prevent the delirium and the collapse and prevent that horrible UTI infection taking over that body for like 3 weeks. So you've got the long hospital stay, then you've got all that recovery period afterwards. Oh. Hello.
Sorry, Mike, bear with us for a second. I think Christina's slides dropped. Let me just see if I can bring them back up.
Okay, I'm back.
Apologies, Michael. I think I was disconnected for some reason for a few seconds, but
that's okay. Thanks, Christina. So where was I up to there? Yeah, so all of that changes the whole way that we would do telecare, because it was always a response service. Now we were moving into that preventative space. And of course, we needed to involve families and communities, and we had to engage with our prescribers to help share that vision, help them understand what it is that they do when they prescribe telecare in the future. Next slide, please. Okay, so onto the learning. There was some resistance to the ADL sensors. Oh, and Christina's having a, okay. There was some resistance by some individuals to the active daily living sensors. Well, actually, more people had a problem with having to wear a neck-worn wrist falls detector rather than a wrist worn, which is quite interesting. And we did that because the wrist worn detectors we found from a piece of research had far more false alarms than a neck worn detector. The time to install this equipment, it just took longer. There were some technical issues as systems changed from simply plugging something into a phone line, plugging it into the mains and then leaving. There is some setup required as you link the sensors to the hub and then making sure that that hub is connected to the call center. As I mentioned before, the digital equipment is more expensive and the cost of the additional monitoring is going to be more expensive as well, because of there's far more alerts arrive rather than alarms. And then how to, when and then to include those prescribers. I think if we went too early, we wouldn't really have anything to tell them to convince them that this was a great thing to do. If we go too late, they feel that all this has been done behind their back. So it's been a tricky balance to find out when to engage with the clinicians around this. Next slide, please. What we found was the use of the language was absolutely vital. I think people felt that some of these sensors were very intrusive, that they were spying, that they were gathering information on the person. And of course they are. But the other way you can describe that is that reassurance and peace of mind, that if something happens, if you fall, if you start to feel unwell, we'll notice and we can come and provide you with some help and support. Using language like preventing small issues from becoming big problems, we found that was very, very effective. And telling people that they were still living in total privacy. There was no imagery involved in any of this sensor technology. As I talked about there, engaging with stakeholders in the right way at the right time, whether that's senior managers within the NHS Trust, all the way through to the practitioners that actually prescribe Telecare. And then understanding the data management, the amount of data that you can is absolutely huge. And we really need to think about how that data is aggregated and used in an effective way. And I think one of the other things is we're very practically minded in the world of telecare. And we had to remember sometimes that we were learning. We forgot that this wasn't just a standard business as usual rollout of equipment that we've been doing for many, many years. There were always going to be challenges. And I think for some partners, it was difficult because they were always so task focused and that they felt that every small disruption, every barrier meant that, oh, this isn't working. But we did have to remember that, you know, if you're going to involve disruption in anything, there's a lot of learning to go with it. And so don't beat yourselves up and be generous and with each other about how to resolve those issues and move on. Next slide, please. Okay, so the findings is the data could have been variable and it's improving all the time. The granularity is excellent. So it's that interesting balance that we saw some traces that saw somebody getting up in the night, going to the loo, and then the back door opening. And we thought, what on earth is going on there? And so we looked at a number of days and over a period of weeks, we saw a very, very similar pattern. And we guessed, because we don't know, but we guessed that the person's getting up to go to the loo. It's quite normal. It's disturbing a family pet, cat or a dog. The dog goes to the back door. The person opens the door to let the dog in the garden. The dog realizes it's 2:30 in the morning, decides it wants to come straight back in again. So what that gave us was that insight into, we know the sensors work and we know it picks up the information that's critical to that person's well-being. But in a way, we're not in the slightest bit interested in that because, as I mentioned, we're really interested in those patterns and the fact that they're detectable and recognized. And it's really, really interesting when we look and we see that narrow bandwidth in which people go to bed with, typically within about half an hour, 45 minutes every night. And guess what? They get up within about a 45-minute bandwidth in the morning, which is great for the system, because if that person's still in bed an hour after they're normally up, that's when it raises that alert. A call can be made and say, is everything okay? And it might be that just having a lie in, which is a great, no harm done. Or it might be that something's happened in the night, that they've soiled themselves, that they can't get out of bed, they're really, really distressed. Instead of them lying there all day until a family member calls in the evening, is we can send a responder out and repair that person's dignity, get everything cleaned up, and they can move on with their lives. As I say, there are some unexplained gaps in the data, and again, we've been working to understand what they are. It's new systems being used in new ways. And I guess probably some of those other typical things that you'd expect in the deployment of equipment across a large area like Wirral is making sure that that installation is correct. What we also found that families were really, really keen to engage. We installed a system at one person's house, and literally the whole family came around to see what was going on and how it would benefit their dad. And the family went away just absolutely thrilled that their dad had this system installed, and it gave them all the reassurance they needed that dad was absolutely fine, still living at home independently. And we're starting to understand now about actually how much equipment we need to put into people's homes. We don't necessarily need a sensor in every room, that 3 might be enough in critical places, along with the door sensors, so that we can see that what we found initially, for instance, was if we don't put the door sensors in, there's no activity, the system starts to alarm, but actually the person's just gone out. So we need those door sensors just to recognize that the person is in the home. So just little things, but make it really, really important for us to understand how the system is going to alert and alarm us. Next slide, please. So the next steps, some of these are already underway. So we now have 50 residents have now got sensors in every single room. We're also about to turn on the temperature measurement facility of those sensors with the forthcoming fuel crisis on winter time. And that's really attracted the interest of our colleagues in the NHS around virtual wards, so that when they send people home with clinical equipment, if they've also got the full digital ADL deployment with temperature monitoring, we can also see that that person's remaining nice and warm. We're testing the machine learning and the AI algorithms to almost to destruction, and to make sure that they are reliable, because we will have to rely on those to provide alerts. And as I mentioned a little bit earlier, we're now doing that data analysis to try and understand a little bit more about what are those precursor signs, what are those signature activities that indicate that some acute episode is about to happen or could happen, so that we can intervene. Naturally, with any proof of concept, we'll be compiling that full benefits analysis and say it's across the piece to the NHS, to the council, to residents, and to Mediquip, who we work with, determine that return on the investment, and then start to make those future investment decisions and create that cost avoidance model with our health and care partners, to ensure that we're getting the most bangs for our buck, that we don't overprescribe, but we also don't miss a trick by underprescribing. And then possibly probably the biggest challenge now, and is the huge, you know, the whole sense of where digital is a disruptor, is how do we redesign services to take account of this new and important information that we can now obtain that's never been seen before, and how does that play out in ensuring that people can live full, healthy and long lives? Thank you.
Thank you so much. That was an amazing example of how digital can be a disruptor, and I really enjoyed listening to not only the work that you've been doing, but the impact that it's having on the end user, also their families. And there was a really good point in the chat from a lady called Louise about impact on staff as well, and how they're then able to use the voice notes, which can support with neurodiverse care professionals. So thank you so much, Michael. And what I also loved about that presentation was the honesty about what's worked and what hasn't, and some of the challenges that you've experienced, because one of the things that I quite often reflect on is that moving to using digital is a journey. And as you said, quite often we're walking down a path that nobody's walked down before, and so we have to learn as we go. There was also some brilliant questions and comments, which I'm going to come to at the end of the session, if that's all right, Michael. So if you're happy to stay with us, and I'll pick that up in a little while. So thank you so much. Lots and lots of food for thought. Okay, so I'm going to turn to our next speaker now. We now have Dr. Simon Bowers. So Simon, I've known Simon quite a long time. He's been a GP partner in South Liverpool since 2002. And as Liverpool CCG digital lead, he led the iLink programme for 10 years. I remember going to a number of those different conferences and particularly enjoyed the Smash the Facts part that you had at those conferences. And that was about supporting the creation of a single electronic patient record across the city. Simon's other previous roles include chair of Liverpool CCG Group and medical director of Liverpool Network Alliance. And Simon now works for a local technology SME developing products for the NHS. So we're really looking forward to hearing your presentation. Thanks, Simon.
Thanks very much, Liz. It always embarrasses me to hear my life story read back to me that I wrote about a year ago when I agreed to do this talk. So welcome, everybody. I'm really, really pleased to be here from my now lovely and warm consulting room. We had some issues with the heating. As you're aware, it's a bit grim on the front line in the NHS at the minute. So let's try and cheer people up. Now, I absolutely adore digital. I've been doing healthcare digital now for about 15 years. And when I saw the brief for this afternoon, this morning, and I saw my colleagues who were going to speak, I thought to myself, what's this word disruptor? You know, it's become a very positive term, hasn't it, in recent years? People talk about Amazon and Uber and the great disruption to the music market and to banking and this kind of stuff as a really, really positive term as we move forward. But when I was growing up, disruption was a bad thing. You got a detention in school if you were disruptive. And I wondered if we could balance some of that out a little bit. So I apologize in advance if anything sounds overly grumpy. I've got permission because I'm in my late 40s and I'm a clinician. So, you know, I'm allowed to be a bit grumpy. Just feedback on some comments we've heard thus far, really. Just to Liz, we absolutely need more of what Liz does. The very idea that we have an organisation that can make life easier for NHS organisations to get this technology to the people we need to get it to. Because as I'm going to talk a bit later on, we don't make it easy for ourselves ever. We need lots and lots and lots more of that. I was really, really encouraged to hear Rachel in her, national kind of strategic role talking about getting this right from school level, and I'd encourage as many kids as possible to do digital GCSEs. I just would also like to see the curriculum a bit more updated to match the actual real digital world. I was helping one of my sons the other day, and he was talking about doc matrix printers and things like this, which is one for the teenagers, I'm sure. And the very concept that data saves lives, this is something that needs to become ingrained in our understanding. I absolutely agree with the concerns that were expressed in the chat about protecting data and keeping people's data safe. But we need to find that happy medium, and we're not there yet. We need to move away from the 90s, where there were scandals when people left pen drives on trains with people's data on, and into an area where there is transparent, honest conversations about data. And there's some great examples of that nationally already, particularly in the Northeast. And then on to Michael. I mean, what an awesome, life-changing project. And he was very positive and very honest about the challenges. And I think he also did really well hiding some of the frustrations. I have absolutely no doubt he's had to fight his way through. And we'll talk a little bit about where disruption becomes a bad thing in that. But just to know that just the other side of the water from me, that there are people benefiting in enormous ways. You cannot stress to people on this call how incredible it is to prevent a hospital admission. The outcomes for being in an NHS hospital are terrible. Now, that's not a comment about my colleagues in hospital delivering care. It's a fact of life that if you are over 80 and you are in a hospital bed, your muscles are aging a year for every day you spend in that bed. So anything that we can do to use digital to keep people at home is incredible. So I'm really excited about all of that. So why am I here? I'm here effectively because all of this is really urgent. The stuff that Rachel talked about in terms of eliminating duplication, of driving automation where it's safe and sensible to do so, and of the agenda around personalization of healthcare. And for those who don't know what that means, 15 years ago, it cost $1 million to sequence a single human genome. 10 years ago, it cost $1,000. Now it costs $100. And by 2025, 26, it's probably going to cost 10 quid to sequence a single human genome. Now, there's a whole load of ethical conversations that go on, and I would suggest that we're not in the right place as a country politically to do that at the minute. But if we did, we could very rapidly enter a situation where your doctor knows what's wrong with you before you do, and that we can do a load of proactive care and prevention, which excites us frontline community clinicians. So let's talk about the rhetoric. Next slide, please. So here's a rogues gallery, and I'm sorry if anybody's feeling nauseous or has been put off their coffee looking at this. This is off my kind of standard rant that those of us delivering digital healthcare have to do so under the pressure of every one of these idiots has an idea in the shower and we all have to jump to deliver that idea. And it hasn't changed for the last 4 health secretaries. I'm ignoring Therese Coffey because she was only in post for about 4 minutes and probably couldn't work a calculator. But the rest of them had their digital ideas that we then all had to deliver. And not one of them was bottom up, not one of them was patient facing. And so the frustration there already that we might have something incredible like a Telecare package, but actually we've all got to concentrate on an app that nobody will use. Next slide. So I spent a bit of time doing this digital timeline, and it's obvious that the stuff at the top is what's happened in my life of digital leadership and trying to be enthusiastic about digital in the NHS. And then the stuff underneath the line is what's happened in real life. And if you can see, since 1990, the world has completely changed. We have moved on from the first online bank and the first online shops to Steve Jobs creating these powerful supercomputers that sit in all our pockets. Delighted to say that my 12-year-old has asked for a VR headset for Christmas. That was a home banker with his dad, I can tell you. And we've seen the collapse of HMV. We've seen the digital disruption provided by Uber. I'm not going to comment on HR and driver welfare issues, but from a digital point of view, there is no doubt that our experience at home with our smartphones in our pockets is very different to those of us in the public sector who come into work. So when I come to work, I have to make sure I'm here at least 15 minutes before I need to be starting clinically, because that's how long it takes my desktop to start up. I would not accept that of my iPhone. I would not accept that of my Mac. I wouldn't accept it of my electric vehicle, but I have to accept it in work. And the question I'm asking is, why am I accepting it? Why am I not making more noise? I'm a vocal digital advocate, and I've let myself down by not being more gobby about that. And you can see a little bit of what I've maybe deliberately and slightly biased put on the NHS timeline is a little bit of a gallery of failure. There's been incredible pockets of innovation. We've heard about some of them this morning, but generally speaking, the big stuff, the big structural stuff is still 15 years behind me being able to walk into my lounge and ask Siri to put the Christmas tree lights on. And yes, I'm afraid we did go that early and our Christmas tree is up. I wasn't involved in the decision, nothing to do with me, but it looks lovely. Next slide, please. So this is EMIS Web in 2009 when we transitioned from EMIS PCS. As you can see, it's fairly functional looking. It doesn't look like any of the native apps you use on your smartphone, but fast forward to now and it looks like this. Next slide. Oh, it looks exactly the same. And this is where you see the negative side to digital disruption. And I'm not going to sit here and criticize another company that I'm actually currently working in really close partnership with. But it is true that in the big procured pieces of software where the market is not naturally disrupted by multiple providers, and if you think about primary care computers, primary care clinical systems, my previous slide said we're spending more than £77 million on these just in England alone. It's a cozy duopoly in our country between two systems, between two companies. And so there's no drive to innovate, there's no drive to change. And I've said this to the senior team at EMIS, every single time they patch and update, my life gets more difficult. The blue circle happens for longer. It's more clicks towards the information I need to get to, from consultation mode to help the patient that's either sat in front of me or is at home on the phone, or I'm desperately trying to use some third-party app to do a video consultation where the phone's dead wobbly because it's my iPhone lent against the top of my PC, trying to do a video consultation and look at a child's rash. So you can see again, that doesn't feel like me FaceTiming me nan in Australia where the pitch is absolutely beautiful and we can do a pub quiz on Zoom during lockdown. My reality of my working life is light years behind the rest of my life. Next slide. And this is the kind of processy stuff I'm talking about. And I think that my experience as a commissioner of digital healthcare and the feeling of banging one's head against a wall versus my experience now, poacher turned gamekeeper, as a supplier of digital healthcare, trying to get commissioned by public sector organisations, has further focused that thought. It's just that now it makes me more angry because obviously we need to sell software so I can pay my mortgage. So I want to send the document securely. You've all done it. You've all done it from your smartphones. Open the phone with your face, 3 clicks, bang, it's gone. It happens all day, every day, doesn't it? Oh, could you ping me that document you wrote? Yeah, sure, bang, I've just done it. However, if I want to do that to a consultant in a hospital, the process is far longer. And very often it will involve deprinting out and scanning. It will involve sometimes even me capturing an image of my screen on my phone and sneakily bypassing all of this NHS nonsense by WhatsApping my mate who's a consultant dermatologist. And there's really, really strong evidence that clinicians, mostly during COVID, but actually, if we're honest, before COVID, have been using WhatsApp to bypass broken systems. And I'm not talking about clinical systems, I'm talking about wider strategic systems in healthcare. So you can see how frustrating that is when my patient thinks that we can behave like they behave at home, but we can't. Everything's a wee bit longer. Liz talked about the smashed facts. I'm so unbelievably proud of that piece of theatre. It was a digital summit we did at Liverpool Stadium at Anfield. So I was in a good mood anyway, just being there. And we got an old fax machine from the then CCG. I had to fill in about 17 forms to get that, by the way. And I got every medical director of every trust in Liverpool City region to come up and hit it with a blue mallet with an NHS sign on that we'd sprayed the night before in my garage. And we all signed up to a charter to get rid of fax machines. This was 2014, 2015, I think. I used my fax machine yesterday in work. There are still some services requiring fax machines. The NHS once sent its then finance director, Paul Baumann, to China to plead with the world's only remaining manufacturer of fax machines to not close because the NHS was the only organisation still using them. And I'm ashamed to say in 2022, we still are. Next slide. Procurement, and this is one that is particularly frustrating to me as a former commissioner. I came back from a wonderful trip I went on with the Royal Liverpool before the merger, the Royal Liverpool Hospital, which was a global digital exemplar. So loads of money from central government to really, really accelerate digital healthcare. There's some wonderful achievements, which I'll talk about a wee bit later. We went to our sister hospital in Boston, Massachusetts General Hospital, and spent a day at MIT, where all the hippies invented hacking and stuff in the 60s. And there was a non-medic, she was a professor of engineering, had created a sensor not dissimilar to the ones Michael was talking about before. This was a wireless router, and it sat in the corner of a room and measured blood pressure, pulse, gait, mood disturbances, skin color, temperature, all kinds of proxies. The research behind it was phenomenal. It was really well clinically validated. And I was sat there with the chief information officer from the Royal Liverpool and the Royal Liverpool's medical director. And the three of us were like, we need this in Liverpool. Came back to Liverpool, got permission, had the funding. Has anyone in Liverpool benefited from this technology? No. Can I tell you why? No. The only answer I could give you is that it's somehow lost in procurement. And this is where I'm afraid our system trips us up. And any of you that have ever tried to do digital procurement of something even vaguely risky or innovative, unless you can leave a little bits of innovative pots around the side where there is an element of being allowed to fail fast. If you try and get a big contract in the NHS, it's going to be a world of pain and more years than you would like. Next slide, please. So I know I've gone a bit grumpy there. So I appreciate this difficult balance. I appreciate that to innovate, you have to innovate safely. And that safely is all about your transparency in terms of who's buying from whom. I'm a Liverpool GP currently trying to sell software to Liverpool practices. So there's a probity issue, there's a transparency issue to make sure that that public pound is spent with all of the right principles of good governance. The governance around both information governance and financial governance and procedural governance, you've got to get that nailed down, you've got to get it right. We have to demonstrate value for money. You cannot spend a single pound of public money on a pet project. Obviously, I'm not talking about PPE contracts there, because clearly you could just waz that money out the door any day as long as somebody was posh enough. And then you've got to have a really, really, really good attitude to risk. You know, we saw a fantastic story from Michael of how they were managing risk in their program, and everything we do that changes is risky. You know, it was risky to move from mercury sphygmomanometers that were toxic to digital blood pressure machines because nobody trusted them. I remember my mum standing by her first automatic washing machine for almost 2 months, worried that it was going to blow the house up. This is the nature of a move into more highly technological fields. Next slide, please. So why are we still here? Why are we still here? I think the NHS, through no fault of its own, right, through no fault of all the wonderful people who work really, really hard trying to deliver this stuff. And some of the most inspiring managers and leaders I've ever met and worked with have been in healthcare digital. There's none of them on the call here today, so I can name a few of them. Kate Warren is a CIO who was my mate in iLinks a long time ago, now CIO of Alder Hey, who is leading a transformation there. And all over Twitter last night, they won another 3 or 4 awards at the Het Awards, all fantastic, innovative stuff that's massively helping children. But Kate's done a lot of that because she's in one organization and she's able to control what's around her. You try and do it across communities. We heard from Michael trying to marry health and social care together, local authorities in the NHS. And those organizational forms don't help us. And then every 4 years, somebody throws it all up in the air and it lands in a different place. We all have different job titles. And we're now having to learn a new set of initials for things. ICBs, ICSs, places. You know, Liverpool's been a city since 1207, 1208, 1207. I now find out that it's now just a place. Don't even know what that means. What I do know is that it means that those people who are making decisions about healthcare at Liverpool are now, from a governance point of view, further away from Liverpool. And I as a local GP, become less influential in driving any good change. Culture is huge. Talked about risk, talked about information governance. We need a good nationwide chat and a proper good nationwide steer. And we saw some of this more permissive environment during COVID. We saw the second iteration of the late Dame Fiona Caldicott's guidance around a duty to share. And from a clinical point of view, for point of care sharing, I welcome that. I've been fighting against people in metaphorical high-vis jackets for years to try and encourage clinical sharing for the good of delivering patient care. And I think now we're at a stage where that data saved lives conversation means we do need to have a different conversation with our public. We need to think about how we get proper, transparent consent for people about how their data is anonymized and used. Investment's really important. You know, the arse fell out of the NHS money-wise about 10 years ago, and one of the first things to go is digital. Now, for digital to truly be a properly disruptive force, they need to do what we did at Liverpool CCG and stick it right in the middle of everything you do. Make it a thing you think about first or second, not when you do HR and estates and legal at the end, because that's what IT used to be known as. Digital is not IT. IT are just the things we buy off Apple and Samsung. Digital is a culture. It is a transformation program that involves human beings. The technology is just an enabler. And then I've already talked about process. There's got to be a way for really good ideas to systematize really quickly. Oh, we've got a couple of slides. Okay, this one will do. So some of the kind of reasons to be cheerful, some of the things that I've involved with have shaped my thinking, and I hope improved life for those people at the time that I was serving. So the telehealth implementation, slightly different from Telecare that Michael was talking about in Liverpool, remains the largest in Europe in terms of delivery of telehealth implementation to patients with long-term conditions. And that's all very well. We put some gizmos. They weren't even particularly digitally sexy gizmos. It was, you know, a big box attached by a SCART lead. Do you remember them? The big tellies in older people's houses. But it was a human-led process with the use of digital champions and the community advocating for this and older people getting involved to show the people how it worked. And the outcomes for this program were phenomenal. It's still running. It's managed by Merseycare now, and they were at the same awards ceremony as Alder Hey last night. And the outputs, which we reported nationally, we saw a 33% reduction in hospital admissions. There isn't a drug that I can prescribe that does that. There really isn't. 33% reduction in hospital admissions. If we could mobilize that now across the board, we might have a chance of saving the NHS. But the thing I was most proud of about that was the patients reported an 89% increased confidence in managing their own condition. We heard Rachel before talk about people being desperate to self-care. They don't want to rely on us people in scrubs. So that was really, really rewarding, and was an example of Liverpool CCG having the right process, the right culture, and bunging £50 million risk on something. It was a nervous afternoon when I took that to the board to try and get 50 million quid for computers and technology. But my colleagues understood, maybe that's because we were clinical commissioners, and maybe the NHS could reflect on removing clinicians from the decision process, which is what it's done now. The I-Link sharing framework, Liz talked about that. We were pioneers really in sharing, and I've still got the bruises to show for it. I remember feeling excited and frustrated when Lord Darcy announced that he was changing his consent process in London for the patients that he was looking after in London, and he just nicked our ideas, which was really interesting. When I was working at the Royal doing the global digital exemplar program, and this was absolutely nothing to do with me, I'm claiming no credit for this whatsoever. They created a very, very simple piece of software that was coded in-house by their own digital staff that just pulled together the data that the nurses were recording already digitally or sometimes manually about patients, pulled it into an algorithm, risk stratified those patients, and then flagged staff on their own devices about who was the sick person on a Saturday afternoon who really needed antibiotics quickly. And that reduced mortality in under 45s, which is, it's one of those ones in sepsis where the figures are actually worse in younger people because they tend to present later. So the mortality from sepsis in under 45s at the Royal was 70%. It's a very, very, very serious medical condition. This digital innovation on its own reduced that from 70% to 35%. Save lives, absolutely save lives. And it reduced the what we used to call all the twos, the cardiac arrest call to patients with sepsis to 0. Nobody was having a cardiac arrest because of sepsis, literally because we were pulling together their pulse, their blood pressure, their age, a few other bits, and alerting doctors when someone was going off and getting poorly. Absolutely phenomenal piece of work. As Liz said, we did 10 I-Links conferences. We started off trying to make it funny with little sketches, but then it quickly grew, and national people and successful companies were getting involved. So I had to be a bit more sensible, and it became online at one stage, including the pictures that you can see there, where I did a VR interview with Matthew Swindells, and I can still just about say his name without getting angry. But that's a whole other story that if we were in a conference, I'd tell you over coffee. But the thing I think that I'm most proud of in terms of all the stuff I've moaned about so far in this talk is the digital clinicians culture, which I can see still happening in some of our trusts where our team have now gone off to work. And this is basically that we don't talk about clinicians and non-clinicians. We don't talk about CCIOs and CIOs. We talk about digital people trying to improve lives for patients and citizens, actually, because you only become a patient when you're ill. So if we can adopt that kind of culture where everybody has a voice and everybody's voice is evenly recognized. We used to have a phrase, no badges on Speedos, and I still use it. In fact, somebody's bought me a poster that I've got up in my room. And that basically means if you're an adult and you're a professional, you don't get to sew your swimming badge onto your Speedos and brag about it. I don't care that you're a professor of clinical pharmacology or if you are a domestic in a hospital. If you've got a boss idea for a digital development that is going to improve lives for patients, then you've got to be heard, you've got to be listened to, and you've got to have a chance to prove it. And that's this digital clinicians culture, which I think is, I still come across Speedos in my job now when I go and sell to colleagues, and it's mostly to GPs because our product is a primary care product. I am regularly patronized by clinical colleagues. I'm afraid it's a bit of a disease that is somehow injected into us at medical school, and I'm on a one-man crusade to get rid of it. Next slide, please. So my final slide, I think, and I always try to end these things if it's kind of after the summer holidays with a Christmas list. And I think this is really, really, really important that we keep begging for this, we keep nagging for this, we keep shouting for this. And if this isn't happening in a process that you guys are involved with, then by all means tweet me and we'll have a banter about it and we'll nag some people. We've got to have freedom to fail quickly. Not everything works. We're at the cutting edge of digital innovation here. I've been implementing the product that we sell in my practice for the last 2 months. And the funny looks I've had from my staff Because I'm a bag of nerves when I'm doing it, because you get bugs. Nothing works the first time, no matter how good your coders or your internal testing is. When you smack it into real clinical data that's been housed in a data warehouse that was created in the 90s, it's going to fall over sometimes. So failing quickly is really important. And a digital clinician's culture approach to that failure is really important. And it's not a, why did we fail? It's a, oh, we failed there. What can we do to get it right next time? It's got to be patient needs led. We heard that story wonderfully from both Liz and from Michael about how the patient voice is involved in everything we do around digital design. I am utterly passionate about digital exclusion, but not in the way you might think. Digital exclusion is one of those things that's being used a little bit like information governance used to be at sessions like this to try and slow people like me down. But actually, I'm a 48-year-old father of 2 who feels digitally excluded as a patient at the minute because the NHS systems aren't good enough for me to properly be digitally included. So if I digitally include all of those people who want to be digitally included, and they are getting more numerous by the day because we're all getting older and getting more native with this technology, then my staff and my clinicians are massively freed up in terms of time to deal with those patients who can't or choose not to digitally include. And the only way we are going to match digital exclusion, because, you know, the old patronizing phrase about teaching grannies to suck eggs, I've got a load of 90-year-olds who are fantastic on Skype, email me like you wouldn't believe, but there's a whole load of them who don't and won't and don't want to. The days when, God, I don't want to be on my iPhone. And so we've got to make time for the system. We've got to automate what we can automate. We've got to take away the duplication so that digital exclusion isn't a thing anymore. It's got to not add clicks to me day. This is where many of our competitors, many of the providers, the suppliers that I have used their system don't think about. And whether it's because they've not got jobbing clinicians in their design process, I don't know. But you're bringing in innovation. It cannot make it more clicks from consultation mode for me, or I'm genuinely not going to use it. And I'm one of the most digitally enthusiastic clinicians you'll ever meet. But if I'm getting a load of blue circle and I'm getting a load of clicks away from where I am seeing my patients, when I'm trying to be efficient, I'm going to try it once. And if it's crap, I'm not going to use it again. Now, I know that goes against the freedom to fail quickly, but I've got me grumpy Friday afternoon clinician hat on now when I say that, and it's just an absolute reality. I've talked about implementation of proven innovation. I think protecting budgets is really important. I got so frustrated as a commissioner with going, well, it's worked. There's the benefits realization. Let's roll it out. Oh, it was only non-recurrent money. Well, what does that even mean, Mr. Finance person? Oh, it means it's not in the budget for next year, sorry. And we've seen that with public health innovations, digital innovations, community innovations for years and years and years. We just need to put a stop to it. If we're spending money on something that works, that money's got to be there permanently. And just as equally important, we've got to be able to cut contracts and get out and stop spending public money on stuff that doesn't work. I don't know how much was thrown at Choose and Book or the electronic referral service, as it was known for all of those years, but it isn't half as good as WhatsApp for what I need to do to help my patients. And then obviously I'd love 3 points for the mighty Reds against Aston Villa on Boxing Day, because it's been a tough season so far, it really has. And I think I'm on my last slide. If you spin on to the next one. Yep, that's me done. Thanks very much, guys. It's been lovely talking to you.
Thank you so much, Simon. Fantastic enthusiasm and passion and reality, actually, from Simon. And it's fantastic to hear about your journey and how now you're looking to not just disrupt internally, but also as an entrepreneur as well, so externally. There's some nice comments in the chat that you can have a little read about. People are saying it was brilliant. They loved the expression "no badges on speedos," and there were some conversations about Northwest employers and the licenses to join corporate rebels. One of the things I just wanted to reflect on from all 3 of our presentations, and we're really fortunate Rachel's been able to join us, so she will be joining us for the Q&A session after the breakout. Was really, there's been a few key themes that have come up. One has been very much about education and learning. You know, we've heard the term fail fast, but we need to learn about this stuff and share. So massive thanks to the organisers for this collaborative in sharing this knowledge, because I think that's where we can really start the journey. And that journey is where we need to get to. That was the second thing that I've been hearing. You know, we are on a journey, but in order to support it, we need to have bravery and strong leadership, and lead from the front with passion. And I think Simon just proved how that can be done. And the other thing is, but we need to be mindful of some of the concerns and the new risks that using digital brings, and we'll come on to that in the panel discussion later. But what we ultimately need to have is trust and transparency. Trust and transparency is absolutely critical, because without that, we're not going to be able to progress. And I suppose that the final thing that I wanted to reflect on is it's a journey that we have to start. And so we're going to invite you now to split into small groups to start that conversation and start that journey. And the question you're going to be invited to answer in small groups of 8 to 10 is, given what you've heard from all of the speakers this morning, and what do you think your role as a leader is to help digital transformation in your organisation, and what is your top takeaway? And we'd like to ask that one person in the group takes a few notes and is happy to share your thoughts and any questions when you return in about 20 minutes. So I think Manal's now going to split us all off into small groups to have those conversations, and we look forward to getting you back in for a panel discussion and hearing your thoughts in a bit. So welcome back. I'm sure that 20 minutes went really, really quickly. So I think that what we were going to do first of all, when you've all managed to get back into the main room, is to ask the facilitators who are a representative from each of the group to share your reflections or questions. Of course, we've got our panel members here as well. So Rachel has managed to join us for this part. There were some points made in the chat, Rachel, which I'm sure you've had a chance to have a look at. I can see Michael's still here, his camera's off, but I'm sure he'll be joining us in a second, and Simon as well. So if you were the person who was taking the notes in your breakout session, if you can put your hand up, and I'll come to you each in turn. Really looking forward to hearing your reflections on the question that we had. So Ben is, I can see that Juliet's there. Ben was the first that passed his hand first. So Ben Lewis, please reveal yourself and share your insights and comments.
I should have been a bit slower there, shouldn't I? Hi Liz, so I think our main takeaway was the importance of working collaboratively and being promoters and advocates of the digital transformation. That's just making people aware of what's going on, what's available, what other people are doing. And then basically having the responsibility to change the culture of organisations, get digital at the beginning of conversations and not just an afterthought. And then also just the point that digital is not just like an IT responsibility, it should be considered by everyone involved.
Yeah, thank you. I'm taking notes, and what I'll do is I'll try and gather some themes from each of the different group leaders and then put it to the panel. So thank you, Ben. Julie, you've got your hand up, Julie Kemp.
Hi, thanks, Liz. We were just very excited into getting into the conversation, so we didn't elect a note taker, but I am a note taker by default, so that's why my hand went up. So we had a really interesting conversation, and actually some of the things have already been mentioned, which is about culture. That's definitely came up. Digital as a priority, because I think a lot of people felt that actually often it isn't the priority, so there really needs to be that buy-in from leadership and actually from all of the staff. We talked about the support from providers of the digital solutions, and actually are they doing enough, and is it actually the right price, so therefore it's affordable to actually access that additional support. And we also talked about education. So one of the things that we were conscious of is that is it actually part of the curriculum? So if you think about people going through university, is the digital solution actually built into that? And if not, well, why isn't it? Because actually it ought to be. So I think those were the key areas from us, and also the lack of focus groups. So sometimes when a solution is being developed by a manufacturing company or an IT provider, we're thinking actually maybe there ought to be more focus groups, and those focus groups need to include the end users, and that might be the patient as well as actually the nurse, the doctor, etc. I think I've captured everything.
Fabulous. That's really helpful, and it's great to hear that there was some overlap with the first group, and then there were two other key things that I picked up there, which was around the cost and collaboration, public and private, and also the curriculum. And I can definitely share your passion for that development piece. I always reflect and say, if I did my degree, which I did over 20 years ago again tomorrow, it's almost identical. But yeah, we're being asked to use these tools. So yeah, really great points there. So I'll come back to the panel and we'll make some responses. So Hayley, if you would like to show your camera and share with us your group's thinking.
So my camera's over there, so apologies, I'm not really looking at you. So I was sort of, again, nominated more or less by default, but we had 3 key topics. So we actually looked at virtual wards at the moment being a hot topic,
yes,
which is sort of quite digital led, and saying really that that's about putting patients to the forefront of what we need to be doing. It's one of the key things is making sure we're able to integrate the various systems and need to do that, that the technology is there to do it, but perhaps the engagement and the end users and the clinicians understanding what they need, it needs to be clinician led to what it is they need on the virtual wards, what data they need to be input into systems. That's probably the trigger of change needed. We looked at what the impact COVID had. So during COVID, decisions were made quickly. Funding was done, it wasn't needed, so it got through procurement quicker. So actually there should be some lessons learned from that. How can we make that fast track that happened during COVID become a bit more of a norm, whereas as is it beginning, there was a bit of a move of feeling that actually it's been slowed down again, but there were some benefits to COVID that we should perhaps try and maintain somewhere. We then had a little conversation about the a positive example with the GPs working collaboratively through the PCNs. That working across so that they've not got separate pockets of money, they're not necessarily fighting each other, and so that's enabling little pilots of work shared collaboratively to be cascaded out. So it's always an example of some good practice going on. There are 3 topics.
Excellent.
We talked about the 111 downtime.
Oh, fantastic. Yeah. Oh no, it sounds like a really interesting conversation. Thank you. I've made some notes for the panel, so thank you so much, Hayley.
Thank you. Well, I'm on voice. Can you say hello to Rachel?
Oh.
And Juliet, I think you were the next one with your hand up.
Hi. Yeah, like everyone else, we didn't nominate, but we've got straight into conversation. So I'll speak up so anyone chip in if I'm getting this wrong. I think we had a more sort of philosophical discussion rather than getting down to the nitty gritty about, you know, the voice of leaders and some of this digital change, and with all the kind of policy changes moving to integrated care. You know, one of the things I was struck with was, you know, when Simon had said in his talk about losing his voice in some of those decision making. So how do we, you know, how do we make sure that that is remedied somehow in the future? We also talked about system under pressure. You know, I've never seen any post-COVID. We've never seen the system under so much pressure. The backlogs we need to get through, the day-to-day working, the workforce issues, etc. And then we talked about kind of really the need to sort of renegotiate our psychological contract between the NHS and the wider population or the public. You know, what really is it we need to use the NHS for, and how then do we educate and make people aware of what they need to do in terms of self-care and what they need to do in terms of accessing other services that prevents that acute touch point in the system that might not have been needed. You know, it was easy to kind of slide into an embattled stance, but really I think what we kind of talked about was that actually digital has a lot of the answers in terms of freeing up capacity in order to do some of the stuff that we've just not got the time to do right now.
Yeah, and I think that was one of the key points that Simon made, wasn't it? That if we can provide people with digital who want digital with those interventions, then it frees up capacity for those people who would otherwise choose to not have digital. So hopefully that means it's a win-win for people. But yeah, some really great points, and I'm really glad that you brought up the pressure. As you say, I think most colleagues working within that pressure cooker situation during COVID, it felt that that was going to come to an end, and it's continuing on. So I think it's a really critical thing for us to discuss. So thank you so much, Juliet. And then Sharon, if I can invite you to share the thoughts from your group, that would be wonderful.
Yeah, of course, thanks, Liz. So in our conversation, in terms of the leadership role, we were talking about that ability to be able to kind of consider the art of the possible. So, not necessarily go straight to the solution or the be distracted by the great new shiny tech thing, but actually, what's the vision? What's this setting out to achieve, really, and what's the best solution? So we talked about some of that, and as I guess linked to that in terms of leadership, there was something about the culture, so not having that fear of failure. So how can we support that and encourage creative thinking? And then we went on to talk about the workforce skills, so that ability to perhaps to think about growing our own talent, so some of the skills requirement to work within the public sector in the field of digital technology and transformation. Have we got the right people? And if we haven't, can we grow our own? Can we develop some of those skills? So we talked about apprenticeships, that kind of thing. And then we moved on some of our takeaways. I guess there was some conversation around public perception and public confidence when we start to talk about data transfer, data sharing, that actually there's probably some wider work there to be done, whether that's nationally, but around encouraging people to see the benefits of some of these interventions and not necessarily be too skeptical of it. So there's quite a piece of work there. And then the other thing that we touched upon was exclusion. So actually, there is something about those people that don't have access to digital technology, and we just need to be mindful of that. So a number of things that we touched upon.
Amazing, yeah, I think again the exclusion point is a really important one that we need to consider. You may not know, I'm vice chair for Tech UK Health and Social Care Council, which is industry facing, and one of the things that I know my industry colleagues really don't want to be is part of the problem of exclusion. And of course, if we're commissioning and procuring digital technologies, we need to be really mindful of those communities who don't necessarily have the tools to receive. And again, I think we have to really think carefully about how we do that. So thank you, Sharon. I'm going to invite the three panelists, Rachel, Simon and Michael, to put the cameras on, and I'm going to ask you some questions that relate to some of those discussion points that we've just been hearing from. And I'm going to start with the probably one of the most challenging areas, because that is what I like to do. Let's eat that frog. So I'm going to, and I'm not expecting you to have all the answers, but maybe just some reflections, particularly around culture. So, of course, working in health and care, we are naturally risk averse, and that's really important. We haven't necessarily engaged with digital in, in the way that where the opportunity might sit. But how do we have a conversation like shifting that culture to make digital the first thing, not just as a sideshow? And I thought I'd come to Michael first of all, and then Simon, and then Rachel, for your thoughts on that.
Yeah, I think it's a quality that comes from leadership, really, and it's that resilience. You've just got to roll and accept that not everybody will see the world your way, but just find different ways to articulate. I think I've found some of the most successful, I think Simon suggested, is just go straight to the patient, go straight to the citizen, go straight to the resident and the benefit it brings them. Don't worry about the machine that gets it there. Think about what the benefits are to the patient. I don't know any clinician that wouldn't put a patient first in that discussion. And I don't know anybody in our local authority that wouldn't put a resident or a citizen first, because that's what we're there for. We're there for them. So yeah, resilience as a leader. just roll with the punches, and use evidence. When you get the opportunity to have a little win, take the results back and just continually show people. It's a drip, drip, drip for a lot of people before they get it. Some people get it really quickly. Others, it takes a long, long time. And we always have to accept there will be those individuals who they've always done it this way. They've been successful doing it that way. Why should they change now?
Yeah, thank you. Really, really insightful. Simon, do you want to add anything to that?
I'd obviously agree with everything that Michael said there. I think for me, working with GP colleagues, I've long adopted, and we had this conversation about referrals and pathways, and GPs want to protect their autonomy to refer. And I've long said you've got to make the line of least resistance the right thing to do. And digital is literally designed for that. And yet the systems I'm using at the minute don't do it. But actually, if we can show our colleagues that we will make a process easier, we are all incredibly busy, and we are all looking to gain tiny little bits of time in our working lives, both clinically and from an administrative and managerial point of view. So if we can find an example that does that, then that's the right thing for the person, the professional. I think the right thing for the patient is, Michael's just hit the nail on the head. You get something with a little bit of evidence that you can't argue against. You simply cannot. We were talking about, we've got some money from Innovate UK to do a cancer inequalities project in Liverpool. And we were talking about how we were going to get resistant GPs to pick it up. It's like, just try and find me one of them that will publicly argue against reducing health inequalities in cancer screening. Even if it's going to make you slightly busier, but actually what you do is you design your product and you design your implementation, because practice managers absolutely are terrified of a dude in a suit turning up and going, we're going to spend all day installing this, and then you've got 2 weeks of training. Modern technology doesn't need that. We don't do that when we download an app, do we? And so it's getting those little details right, so that initial experience, you got to think, we are all, any of us driving change, we're salespeople. I'm now literally a salesperson, but we've been selling ideas for years. If you got in a brand new car and there was dog poo on the mats, you wouldn't feel good about it, would you? But that's literally what we do to our professionals all the time. We give them stuff that doesn't make their lives easy.
I'm loving your analogies, Simon. People are going to have a visual and
it must be the lem sip. I apologise for that one.
Sensory memory now. But no, very good, thank you. Rachel, I don't know if you want to add anything to that. So culture, and how do we get digital on the agenda?
So Michael's piece about evidence, absolutely crucial. Data saves lives and improves lives. And, with data saves lives, we prove the lives that were being saved and improved with digital technologies and data. We need to do more of that. We need to close the loop. But coming back to what Simon was talking about, metaphors are very good. Using metaphors and comparators, right? So digital is the new infrastructure, and in a lot of cases it can replace hospital walls, clinic walls, whatever. And if you can basically say, you wouldn't architect a building as a kind of Nissan hut built out of corrugated iron or whatever. You build it properly, you architect it properly, because we know how important it is. Just because digital and data is less seen, you can't walk up to it and see it in the way you do a building. You can't ignore it and pretend that you can half architect it or half invest in it. But also there's the story of where society is going, what are other industries doing? What's banking doing? We can have comparators there. And I think, listening to Simon, sales, I think about it as movements. We're starting movements of people that can get behind a message. It's about dialogue. It's about leadership, and it is hard. You get knocked down. You get people, who really want to fight the message. I get really curious now. Why is somebody so opposed to this? What can I have in, as a dialogue with them? But overall, we need to do the right thing. We've got a set of tools, techniques, technologies, which can improve lives and save lives. And we've got kind of that Hippocratic oath to do the right thing, I think. And so getting people behind the message and also getting them as part of the stakeholder group, getting them engaged, I think that's the most important part. But it's not an easy job. And certainly, a decade as a CIO, I would constantly get knocked down. So the most important thing for us as leaders is to have your sanity group, as I call it, people around you that are doing the same thing, who you can make a phone call to and go, oh, I'm having a bad day, or this has gone wrong. But you can also borrow them to take into meetings or boardrooms, or borrow their evidence. And this is a team sport. It's not for lone wolves in any way.
Oh, fantastic. Thank you so much. And I was just going to add one other thing. One of the things that I find from working with lots of different systems, both here in this country and other countries, is start with real clarity on the problem you're trying to solve, and make that problem very, very specific and measurable, and then it drives evidence, and then have that continuous loop of feedback. You will have done that many a time with therapeutic interventions and other changes that you've led across your workspaces, but it's exactly the same with digital. And I know that when I've gone into some organisations to talk about the work that ORCHA do, I've stopped talking about ORCHA and said, okay, what's the problem that you're trying to solve? Because I'm not quite sure whether we're the right solution for what you're trying to do here. So let's really nail what the problem is. And I think that's really powerful, because it then, as Michael said, connects us to the desired outcome, which is always patient or citizen focused. Okay, there's lots of other things for us to talk about. Well, one of the key themes that I've really heard has been around education. How are we feeding this into curriculum? I shared, if I did my clinical degree again tomorrow, it's not changed that much, but the tool set really has. How do we support our frontline health and care workers to be able to engage with these tools by training in the first place? And I quite often sit on panels where people will say, oh, but it's clinicians that are the resistant people to this. It's them that don't want to have the change. And I quite often say, well, you wouldn't ask a doctor to prescribe a drug without all the training that they've had. And we're literally asking them to engage with interventions. There is no training, therefore. So I'm going to come to Rachel first because of your work in the NHS Digital Academy. And then I'll come to Michael and then Simon for your insight.
Absolutely. And I think we've all been really honest. I've heard Simon be really honest. My frustration at the moment is with the Department for Education, because you have to start really early with people understanding their careers here and jobs, and our Department for Education does not change easily. All kudos to Dame Wendy Hall, who is trying to get them to change in terms of the kind of portfolio of digital careers. That needs to really change. But education needs to be lifelong learning, and it needs to be embedded in every piece of education. Obviously, we've had the Digital Academy in the UK, but that's only touched a fraction of the people that need to be part of this, learning and development. And I cannot blame doctors, nurses, professionals for saying they don't want to touch solutions, because, I don't think I would have wanted to drive a car without having had some good tuition first. You don't feel safe doing it. We really need to invest in this. And actually the work I did with CLASS, which was a global survey of nearly 500,000 clinicians, found the most impactful thing that you can do in terms of getting people confident, competent, and delivering high quality care with digital solutions was provide high quality, appropriate education for them. Yeah. And also callback education resources. And there is a direct link between education and the quality of care delivered by clinicians using digital resources. For me, that evidence we need to act on, and we need to actually invest in education. Again, it's another hidden thing. It doesn't look like a building education. You can't actually see it. We need to use metaphors, evidence, and everything we can to actually make sure we've got, the CPD and the qualifications for clinicians, and that we put the right emphasis and weight on it.
Thank you so much, Rachel. Michael, I don't know what your experience of this has been.
Yeah, I guess not unsurprisingly, but specifically around telecare, it's only really, or digital telecare, it's only really been a thing for about 2 or 3 years, when we found out that BT Openreach were being instructed to turn off all the analog telephone lines. So I fully appreciate being an occupational therapist or a physiotherapist or a nurse, not really understanding how to go digital first. Just listening to me banging on in the background, telling them what to do, it's not going to work. So I think it goes to the point that Rachel made, is it's the lifelong learning, it's the CPD stuff. But we were quite shocked when we started to look around as a city region. So we're fortunate enough to sit in a group, and there actually wasn't anything. There really wasn't anything to guide practitioners on introducing digital telecare. So we wrote our own. Literally just sat down and as a group of 5-6 people with some knowledge of telecare, wrote our own. And then we run into the organisational stuff that Simon pointed into. Well, Sefton Council in this case were very happy to use their resources, but then we figured, well, let's sell this product. Let's have it as an as an investment tool. And then you just run into all these barriers. It's like our organisations like ours, they're just made to spend money. The very notion of having any sort of income from our activity, it's like a complete anathema. Our finance team get really quite concerned about, well, how are we going to manage it? How are we going to code this income? I think for the next decade at least, possibly even longer, it's going to have to be through CPD learning, people coming into healthcare, into social care, and learning on the job. And I think then slowly but surely, with leaders, like ourselves, particularly people like Rachel, to then have it as modules as part of their social care training, modules as part of healthcare training, so that at least by the time those individuals qualify and get all their post-qualification work out of the way, things will have moved on, I'm sure, enormously in that, even in that like 3 or 4 year spell. But at least they'll have a grounding, and there won't be the fear and the apprehension around a digital tool.
Yeah, I think that's right. And one of the things that I quite often reflect on is, our education is, if we think about learning in this space as a pyramid, most people are at the bottom of the pyramid, and at the top are the champions of the system. And of course, if we're going to grow more champions, we need to start to rise from the bottom. And as you've said, it's about, for me, just lifting people's knowledge, just a small amount, so they're not scared, so they can start that journey. And that's a theme I've definitely heard through all the conversations and the presentations. Simon, do you want to talk a little bit about training, education, learning?
Just 3 very quick things for me. More power to Rachel. I've got 2 boys in secondary school, one in year 7, one in year 11. I asked my year 11 directly, why aren't you doing computing, as it's still called, GCSE? And he said, Dad, have you seen it? And I looked at it, and it's really boring. I mean, it is really boring, because I look at it and think, that's the one lesson of the week they should really look forward to. They should have VR headsets on. They should be looking at AI, all that kind of stuff to get them hooked. And then you do the more life skill stuff. It shouldn't be about, well, you've got one lesson of coding in 3 years and the rest is learning about binary bloody numbers. So that was that quick one. Second one is our young clinicians that are coming through. We're training practice here. We have medical students as well, absolute digital natives, and then we're training them backwards. So we're teaching them how to find ways around crap systems. So that's damaging them at the start. And then I guess for me, for our wider systems and for the cultures within our organizations, I think a proper educative chat about emerging technologies. So I'm going to use artificial intelligence as an example. There's a huge number of products out there that say they are AI, and they're not. It's algorithms like I used to code on my Spectrum when I was 11, and that's absolutely fine. It's completely legitimate, completely credible, but don't call it AI just because AI is sexy. But also to talk to those on the ground, and particularly those with budgetary responsibility, about the risk and safety balance of emerging technologies. Because the second I've spent a couple of years now learning how to develop a product, which I've never done before in my life. I'm not at all technically based. And the learning curve has been exciting and terrifying in equal measure for me. But we know when we reach that Rubicon, when we reach that sign where we've got a bit of functionality, we think, oh, that's going to be so exciting. But I know that my clinical colleagues who are currently the purchasers because of the partnership model in general practice will think that seems a bit AI-ish to me. Not having that's dangerous. And it's the same conversation that we were having about IG 5 years ago, by the way. So I think that they're the areas where I'd concentrate.
Yeah, no, thanks for that, Simon. And I think that you're right, we need to normalise this, we need to put it into our children's education, we need to put it into the education of our future health and care workers and professionals, and it needs to just be something that's embedded. I think that we're on that journey. You know, that is a theme that keeps coming up. I think where we are now, there's pockets of amazing things that are happening. So I'm sure, Michael, people will be reaching out to ask to see the training that you developed. I put in the chat the work that we did with Health Education England, which is an academy which is very much from that bottom-up perspective. Rachel's got some amazing stuff that she's been doing. There are some great universities across the country and across the north as well that have master's and degree level modules that you can undertake. But I think at the moment it is a little bit like there's pieces of the jigsaw puzzle on the table, but they've not quite come together. So let's learn from each other and keep sharing resources. I'm really sorry to say, I think that that's probably as many questions as I can ask our panel. I could carry this discussion on all afternoon, actually. There's still quite a few questions that were left open, particularly around could the technology, and Michael, maybe you can answer this in the chat, that you were talking about support with single room hospitals and reduced nursing support. There was some great comments around some of the challenges that digital bring around data sharing and that trust area, which Simon just touched on, and around how do we create a more radical shift given that we're now moving to ICBs, and make sure that the NHS and care sector work closer together. So there's lots and lots of other points that we could come on to, but unfortunately we have reached the end of this masterclass. It's really gone very, very quickly, and what I wanted to do was, while we've got a couple of minutes, invite you to just stay. I think that somebody's going to share a slide now, which has got a QR code, and please do complete the event evaluation. It's really powerful for the organisers to be able to know what went well and how they can improve for next time to hopefully get more benefit to you. While you're completing that, don't forget as well that there's another masterclass that's going to be happening on Thursday, the 8th of December. And that masterclass will be joined by Damien Hughes to explore the psychology behind leading high performance teams. And of course, that's something that's really come up today. How do you all as leaders go back into your organisations, talk to your colleagues and lead the way forward, but how do you also help them to be high performing in this area? So thank you so much for your time. Thank you so much for taking the time to complete the survey. It's really appreciated. And finally, I want to thank the speakers who have just been amazing, and I'll hand back to Juliet or Anne-Marie now. So thank you very much for inviting me to share. It's been a real pleasure.
Thank you, Liz. That was fantastic. Yeah, lots of great content. And thank you, Liz, so much for chairing this session so brilliantly and so energetically. I just want to say thanks also to the team behind the scenes, so people that are keeping the swan's legs. It makes this session move so smoothly. So thanks to Manar and Christina and Pam and everybody else that's on Twitter, etc. Thanks to the whole team. And if I've not mentioned you, it's nothing personal, I just can't remember. So without further ado, go and have a nice lunch and have a good day, and just thanks again.